Hi, good evening, everyone. So I'm very happy to invite and welcome our esteemed speaker today. And she hardly needs any introduction in the field of neurocritical care. However, it's my privilege to introduce Dr. Chiara Roba. And she's a distinguished leader in neurocritical care research, particularly in context of acute brain injury. Dr. Roba is a professor of anesthesia and intensive care at San Martino, Genoa, Italy. And she serves as a chair of neurointensive care section of European Society of Intensive Care Medicine. And equally pleased to have Dr. Nitin Manohar, and he's well known to our society people. And Dr. Nitin Manohar right now is working at Cleveland Clinic in Abu Dhabi, and he is also collaborator for the Ventibrain trial. So I welcome you on the behalf of Neurocritical Society of India, and thank you very much for joining. So to begin with, let me ask Kanchan to introduce herself and Deepak also, and begin the study. Kanchan, can you unmute yourself?
Thank you. Good evening, one and all. Welcome to this edition of NCSI Bulletin. And this time we have a journal club where we have the privilege of interacting with the investigators themselves. So it's going to be a great discussion. We read this article with a lot of interest, and it's an interesting article because it um, shows us where we are in terms of lung protective strategies in acute brain injury. We are on a day-to-day basis in the quest to get it right every day. So thank you, Dr. Chiara Roba, for your time, and Dr. Nitin as well. And joining me here is Dr. Deepak, a neuroanesthetist, currently serving as a faculty in the National Institute of Mental Health and Neurosciences, Bangalore. And I am also an alumnus of the same institution. And currently, I work at a mission hospital called Chinmaya Mission Hospital in Bangalore. So it's a privilege to moderate this session, and let us dive into the topic without any further delay. Dr. Deepak will take us through the a review of the existing literature regarding ventilation in acute brain injury. So over to you, Dr. Deepak.
Thank you, ma'am. And good evening, everyone. For next few minutes, I'll be talking about lung protection strategies in acute brain injury. So we all know the lung and brain interactions, and we know injury to one organ leads to the injury to the other and vice versa. So let us see, there is a acute brain injury patient on mechanical ventilation, and I want to protect the lung. So there are few strategies like lowering the tidal volume, limiting the plateau pressure, optimizing the PEEP, avoiding high oxygen concentration, and sometimes positioning in prone or recruitment manners. The problem with this is physiologically it causes hypotension and raise in intracranial pressure, which compromises cerebral perfusion pressure. So here comes protection of the brain. So how do I balance that? Because currently the evidence and the practice and recommendations are towards maintaining eucapnia, avoiding hypoxia, and keeping the head up position, and maintaining adequate volume, and sometimes osmotherapy in the air. So again, closing the loop, now what do I do about lung protection? So now looking into the published literature, I went through this. The first study is secondary analysis of INEO study, which came in 24. This is a part of the result I want to show, where you can see the PaCO2 level at U-shaped relationship with in-hospital mortality. So as you can see on my screen, the majority of the patients had normocapnia during their stay in the neuro ICU. As the carbon dioxide raised towards 45 and above, the hazard increased, and also you can see in cases of severe hypocapnia, the results were same. So in this study, it was seen that mild hypocapnia and normocapnia had less hazard than the severe hypocapnia and hypercapnia. Another study from Norway where it was a crossover study where low tidal volume with low PEEP and low tidal volume with high PEEP were tried in same patients. As you can see in each patient, there was a baseline washout period too. So out of 27 patients, they found that only 6 patients had interruption in the intervention because of raise in ICP. Rest of them had ICP rise by 2 to 2.5. However, it was clinically not relevant. And in the same study, it was seen that autoregulation and regional oxygenation was intact throughout the study. This is the randomized controls trial, which was done in acute brain injury patients, where lung protective strategies was compared against the conventional strategy. So as you can see, the conventional strategy had tidal volume of 8 ml per kg with a PEEP of 4, whereas lung protective strategy group had tidal volume of 6 ml per kg with PEEP of 8. In this study was stopped prematurely because of lack of funds. However, the results were published. In that, the mortality and composite outcome, that is death, ventilator dependency, and ARDS, were higher in lung protective strategies, and there was a relative risk which was higher in the lung protective strategy group. Next, looking into the recommendations from European Society, which came in 2020. As you can see, the ventilation, on ventilation recommendation, the PEEP is recommended same like any other patient in intensive care when patient's ICP is under control. Coming to PaO2 and PaCO2 levels, the PaO2 levels were recommended anywhere between 80 to 120 and PaCO2 35 to 45. As you can see, the evidence for this is very low, or there is hardly any evidence to support this. So with this, there is hardly any evidence which clears our doubts regarding how to ventilate, how to protect the lungs in a patient with acute brain injury. So now with this caveat, I leave it to the authors of Ventibrain study to take over and discuss the results in detail and give us some light.
Thank you very much. If you can hear me, I will start. So I would like to start from how we decided to do this study. It's true, everything Deepak said so far, because there is an important interaction between the brain and the lung. And what I always say is that at the end of the story, isolated brain injury doesn't exist, because every time you have an initial brain injury, this causes a cascade of events which are not inside the brain, but are systemic events. And then if you think about some treatments that we use for treating ICP, the brain, etc., sometimes they are detrimental for the lung and for other organs. What is interesting in the literature is that the ARDS in brain-injured patients is very, very common. Consider that only a minority of brain-injured patients arrive already with an ARDS. Those are mainly the trauma ones. But the pooled incidence of ARDS in brain-injured patients is around 19%, which is a lot. Why? This study describes this, but describes also the fact that over the years there is a reduction in the incidence of ARDS. And in my opinion, it's probably because the concept of lung protective ventilation is gaining more and more interest even in brain-injured populations. This is an important topic that we decided to explore because basically when you have a brain-injured patient, you know that the mortality is already very high, but the addition of the pulmonary complications worsen a lot the mortality, the prognosis, and the neurological outcome. So we have started to review initially all the literature available. And when we started this project, I was working with Paolo Pelosi, who was my boss. And as you know, he was the chair of lung protective ventilation strategies in non-brain injured patients. And he has done a lot of work with a Provenet network to demonstrate that being protective in terms of pressure can improve the mortality. And this is for both ARDS and not ARDS patients. But if you look at the paper from Paolo Pelosi and these big trials, in the exclusion criteria, there is quite always the presence of a neurological injury or the presence of intracranial hypertension or neurological patients. The reason why they did this kind of studies with these exclusion criteria is that they were scared about the physiology, as rightly my colleague was saying. From one point of view, if you use high intrathoracic pressure, like if you use a recruitment maneuver, etc., you might have a reduction in the outflow and you may have hemodynamic instability. Also, if you think that the concept in the general ICU population is that we can leave permissive hypercapnia as long as the pH is preserved, this cannot be allowed in brain-injured patients, because hypercapnia can cause an increase of the intracranial volume and therefore complications. So, because of all these reasons, I think there are some false beliefs in the management, in the ventilatory management of brain-injured patients. First of all, for instance, is that the more oxygen we give to these patients, and the better it is. This is not true, because there are evidence which now demonstrate that even hyperoxemia can be very detrimental. And of course, hypoxemia remains a huge cause of secondary brain damage, but we should not even target too high values of oxygen. The other point, for instance, is the PEEP. Traditionally, brain-injured patients are ventilated with very, very low PEEP or zero of PEEP. But the presence of zero of PEEP is one of the major determinants of pulmonary complications. Recruitment maneuver, ECMO, prone position are forbidden. We have to use very high tidal volume to control the CO2. These are all sort of false beliefs in this population. So this is where basically we start. And this is an editorial from Shirin Frisvold from Norway. She wrote this interesting editorial which basically describes the different targets and the different effects of different strategies according to the brain and according to the lung, when especially it is damaged, and potential final recommendation. But these recommendations are not based on evidence at all. This is an editorial. So we started this process using databases from other populations, so post-hoc analysis, not specifically studies focusing on brain-injured patients. This is a sub-analysis of the TTM2 trial, so we are dealing with post-anoxic cardiac arrest patients, so are for sure patients at risk or with increased risk of neurological complications and cerebral edema. And what came out in this study is that some parameters are associated with outcomes, for instance, the driving pressure, the mechanical power, the ventilatory ratio, and the respiratory rate. And there is a formula which you probably have read in non-brain injured patients, is a formula which was applied in a ARDS patient, which is 4 per driving pressure plus respiratory rate, which was the strongest parameter associated with poor neurological outcome and with mortality. So the idea from this paper is that even in a population at risk of brain injured patients, if we are protective, probably the outcome will be actually better. Then the second step was or parallel step was to understand which was the practice, because when you plan an observational study, the first thing is that you have to see which is the practice from the clinicians. So this is a survey from the European Society of Intensive Care Medicine, where we asked to the physicians which tidal volume would you use according to the presence of brain injury, according to the presence of different grades of respiratory failure. Which PEEP would you use? And the final concept of this survey was interesting, because it was looking like if physicians were not anymore scared about using low tidal volumes or even high PEEP in cases when there is an ARDS. And so we did another step. So we took three different databases, and we looked over the time what was happening in the respiratory settings. This is a graph which represents three cohorts, 2004, so we are talking about 20 years ago, 2010 and 2016, and there is a progressive reduction in the median values of tidal volume. If you think that in 2004, the 30% of the patients were ventilated with tidal volume higher than 10 milliliter per kilo predicted body weight, and in 2016, it was only the 9%, so just a minority. In the opposite way, it was the same thing about the PEEP, because in 2004, here you have a median value of PEEP of 4, which has slightly increased. But what is important is that in 2004, one third of the patients were ventilated with less than 5 than PEEP, and in 2016, only the 8%. So this made us understand that clinical practice was changing. Clinical practice was changed, but it was still full of question marks. So we decided to write the guidelines, but as you will see from this paper, which takes in consideration different factors, these guidelines are based on systematic reviews, meta-analysis, but very, very low level of evidence regarding everything. But what we asked to the expert is, would you use a lung protective ventilation even in brain injured patients, especially if in that moment they don't have unstable intracranial pressure? And the answer was yes. Strong agreement on this topic. And the other point is, would you use ZIP in brain injured patients? And we obtained a strong agreement regarding not using ZIP. But the suggestion from this consensus was to use the same level of PEEP that you would use in non-brain injured patients. And this is something which comes from some physiological studies. This is a study that I did with Paolo Pelosi in 2021, using quantitative computed tomography study with increasing levels of PEEP and segmentation of the lung. And what was found here is that the area of atelectasis which were recruited were associated with the changes of intracranial pressure, which means that if we set a value of PEEP which allows to improve recruitment without causing hyperdistension and hemodynamic instability, PEEP can be safe in this population. And of course, we have to do it very gently, because this is the study that my colleagues showed you before. This is one of the 6 patients where there was an increase of the ICP, and then the patient had to be stopped from the monitoring. But look at how it was planned, this study. In the lower part of the slide, you will see the tidal volume and then the PEEP. In white, you can see the ICP and the CPP and the ABP and the CO2. The changes of tidal volume were very, very quick, together sometimes with very quick changes of PEEP. And also, PEEP was not titrated on the specific conditions of the patients. So I'm not surprised that in some cases there was an increase of the ICP, as you can see, which is mainly related, if you see, to an increase of the CO2, quick increase of the CO2, or to a reduction of the CPP. So it's also the way and the velocity from which you set the ventilatory strategies. So after all this work, we planned the Ventibrain study. The Ventibrain study has been conducted in 72 ICUs in 26 countries. So I think there is a very good representation of all the centers, and I really would like to thank Nitin and all his team who have participated, because they really provided a huge help in understanding this topic. And the inclusion criteria of Ventibrain were patients with acute brain injury patients, which were defined as traumatic brain injury, intracranial hemorrhage, subarachnoidal hemorrhage, and ischemic stroke, who required ICU admission and invasive mechanical ventilation. We collected the data regarding all the ventilatory settings every day for the first week at day 10 and at day 14. primary outcome was the 6 months mortality and unfavorable neurological outcome. This is the flow chart of the study. We collected initially 2,136 patients, screened for eligibility. Some of these were eliminated in terms of presence of data, withdrawal of consent or medical decision, etc., for a total of 2,095 patients in total. On the right, you can see the characteristic of the patients. So there was a 66% of male, median age of 58 years old, 61% from high-income countries. So this means that we have a very good representation of low-income countries. ICP was collected every day in the morning, and then it was detected over the day the highest and the lowest value of ICP. And putting together all these time points, we observe in this population a 22% of episodes of increased ICP. The majority of these patients were TBI, 40%, intracranial hemorrhage, 27%, subarachnoidal hemorrhage, 19%, 13% for acute ischemic stroke, with a median GCS and admission of 7. Here, because I think that this program doesn't allow to use the animation, because this is a second figure, but I will explain you everything. So here you can see the median value of the different ventilatory parameters. So here you have plateau pressure, driving pressure, tidal volume, PEEP, respiratory rate, and FiO2 daily. So day 0, 1 at admission, the first week, then at day 10 and at day 13. And in red, you can see the median value. In green and in blue are dichotomized according to the presence or not of increased ICP, of episode of increased ICP. Because one of our aims was also to understand whether ventilatory strategies were different in case of increased ICP. The results are these. So the median tidal volume was 480 with a predicted body weight tidal volume of 6.5. So it's quite low. If you think that in this cohort, only less than 3% had the ARDS. Median PEEP was 5, with a median between 5 and 8, and ZIP was present in 0.9 of the patients. So very, very rare. Median FiO2 was 40, respiratory rate 15, P-peak 20, so very protective as type of ventilatory strategies, P-plateau 15, driving pressure 9, and mechanical power 12.7. So in general, I would say a very protective lung strategies. And doing a logistic regression analysis over time of the difference between the presence of ICP and or not, we didn't find any difference in the ventilatory settings. So this means that regardless the presence of increased ICP or not, these are the values which clinicians maintain. We can speculate on this, we can discuss on this. My first take was that probably are even in the presence of ICP, clinicians prefer to use other strategies to control ICP rather than, for instance, the CO2. They use more mannitol, my hypertonic saline, etc. But they maintain a lung protective strategies. This is a graph which demonstrated the heterogeneity across countries regarding the different strategies. On the left, you can see all the main countries. And here, each country is a dot with a confidence interval. And basically, what we can appreciate in the different ventilatory setting is that there is a very, very high country-to-country variability. And this was especially true for mechanical power, for PEEP, for driving pressure, and for respiratory rate. And the lowest variability was reported for PEEP-LAT and tidal volume for predicted body weight. Even in this case, we can make some reasoning. My first take in this sense is that Probably we have the strongest evidence regarding tidal volume and plateau pressure, because we have the huge randomized control trials which come from the general ICU population. Maybe some parameters like the mechanical power or sometimes the driving pressure are not routinely used or measured at the bedside. So probably clinician tends to put more attention on plateau pressure and tidal volume for predicted body weight. And these are the results, the association between the ventilatory settings and 6 months mortality. So we found a strong association between different parameters and mortality, in particular the plateau pressure, the driving pressure, and this was a very linear correlation. Quite similar correlation was for FiO2 with a more plateau area between 20 and 40%, but above 40% there is a very high increase. We found a U-shaped curve regarding PEEP and regarding the respiratory rate. And I feel that this is related to the fact that PEEP should not be, is not too high or too low. If it is too low, probably it doesn't help the lung. If it is too high, probably it doesn't help the lung and not even the brain. So PEEP should be individualized and titrated according to the patient's conditions. And here, if you see something that was surprising us a bit when we looked at the result, is the relationship of tidal volume for predicted body weight. Look that there is an inverse correlation. So this means that the higher is the tidal volume, the better is the outcome. So this initially surprised us a lot. But then we explained this in the following way. Being protective probably is not just about the volume. Being protective is about the pressure that this volume causes. So as long as the plateau pressure is maintained as protective, we should probably target to a slightly higher tidal volume. Why? Because in these patients, we have to control very well the CO2. This is my interpretation, but I think it's physiologically reasonable. So protective ventilation is more about these factors, and as long as the plateau pressure is maintained and the driving pressure is maintained, the volume which is within these two values should maintain to allow to target a good value of CO2. We didn't find any correlation with 6 months outcome except for the FiO2 and well, of course, except the compliance, which is not really a setting, but it's a consequence of lung injury and of the settings. For many reasons, I think. We used the GOSE, which is a scale that is easy to be obtained and which is the most used scale. But GOSE doesn't allow to provide probably too specific values and description of the quality of life of a patient. So probably is not enough granular to detect this. So starting from these results, of course, we will proceed with working on the sub-analysis, and we would like then as next step to do a randomized control trial, but the strategies to be adopted in this population is to use low tidal volume, but be careful not to be too low. Consider mainly the plateau pressure and the driving pressure. Try to minimize also the respiratory rate, considering again regarding the tidal volume. PEEP should be individualized and should be enough to keep oxygenation and to keep a good recruitment, but at the same time, it should not exceed to avoid hyperdistension and hemodynamic instability. There are also other recommendations regarding the rescue therapies in terms of ventilation. The thing that we can further discuss is a bit this, because as I told you, the majority of the patients in the Ventibrain study were patients with quite a healthy lung, because the median PF was around 300. So they were not, as a first looking at the compliance and the ventilatory setting, they were not patients with NARDS. What will be interesting to see is what happens when you have both ARDS and increased ICP, which is not very common. We have seen it, but it can happen. And in this editorial, basically my idea is that if you have a staircase approach to treat ICP, and if you have a staircase approach to treat the ARDS, these two staircases put together create a much more complicated figure, which is this one, where you have here the tier 1, tier 2, tier 3 in terms of ICP control, and here you have different worsening conditions of ARDS, mild, moderate, and severe ARDS. And probably we have to be ready to skip the normal approach of a staircase approach. I would like to thank you for your attention, and if you have any questions, I am available.
Being applied on such patients. So we have some questions ourselves, and the audience has also posted some questions that we will take one by one for sure. So this was a mammoth task, we understand, because it is truly international, involving so many countries, so many hospitals, 26 hospitals, and multiple clinicians. So if I may ask you to list three main challenges that you faced and overcame during this study, what would they be?
So the first, I'm not sure I have overcame the challenges, first of all. So when you build a trial like this, you really would like to have the representation of all the world, because if it is observational, you really need to understand what is happening to all over the world. So we contacted the different centers according to our contacts, but of course not all the centers. For instance, you have seen that there are not Australian centers in this trial. So the first challenge was the recruitment of the centers. The second challenge was the homogenization of the data, because at some point we had to get in touch with every center for the missing data, for the problems related to some numbers which, according to us, were not completely true. And this led to a huge amount of work in terms of email, phone calls, discussion, because we wanted to be super sure that the data we had were very clean. Okay, so this was our main, and were true. And sometimes it was also interesting because in some cases we thought there might be a typographical mistake, for instance, in some values. And then when we contacted the center, they said, no, it's true. Like there was a center where they used in all patients like 800 millimeters of tidal volume. So when we look at the data, we contacted the center. Are you sure that it is correct, or maybe it's not a typo? And it was true. So, but it's also fair to present this, because this is the clinical practice. So we have to think that this is the picture of now how doctors behave, and on the basis of this we have to work.
Okay, that's really interesting because we have to bring all the clinicians together to follow evidence-based medicine. And this is a huge step towards creating evidence and looking ourselves in the mirror as to what we are doing. And so that's really great. And also, you have mentioned mechanical power and driving pressure as some of the parameters.
Sorry.
Yeah, that's okay. If you just want to grab a glass of water, that's fine. Okay.
Go ahead.
Thank you. I hope you're better. Yeah, so normally when you look at ARDS strategies, so we have these definitions. We know we step up on the PEEP, and the FiO2 is regulated. So we would like to see now more and more discussion regarding mechanical power and driving pressure happening in the ICUs. That's what a lot of studies are looking at. So could you just elaborate on that, please?
Yeah. So
And
I am a strong believer in these parameters for a very physiological reason. When we talk about being protective, we don't really have a definition of being protective. Is 6 of P protective and 8 is not? Is 6 of tidal volume protected and 8 is not? Nobody demonstrated what is protective and not protective. So, in my opinion, driving pressure and mechanical power simply represents a combination of factors. Driving pressure is the plateau pressure, which takes in consideration the tidal volume and the PEEP. The mechanical power, according to the formula that you use, must takes in consideration the real work that is done by the lung. It includes the respiratory rate, the plateau pressure, the PEEP. So I think that regardless the different formulas, the concept is that protection is in toto, is not just one parameter.
okay, so we look at lung parameters and we also look at our brain protection strategies, hemodynamics, and combine all these to protect the patient as a whole, not just one organ,
Yeah.
right? Okay. And then, so it was also very interesting. You noted this point that we are no longer just looking at the CO2 to titrate the ICP, to control the ICP. And we know for a fact that there are a lot of other factors that increase the ICP, which need to be controlled. And one using the tiered therapy is the approach to go, and not just overventilating, hyperventilating the patient. And most of the patients did have eucapnia.
Yeah,
Yes.
you mean for we using the CO2 removal?
Yes, yes.
So
So
there are so
it's
far
good to
only,
see.
yeah, is some case reports on the CO2 removal. As you know, CO2 removal is not being recommended in ERDS patients. So in the point that I have is that probably in general ICU population is less used. But personally, I think that in brain injured patients where you cannot control the CO2 and the CO2 becomes a problem for ICP, there is an indication for CO2 removal.
Okay, so that answers the question from one of our audience regarding extracorporeal CO2 removal. Okay, so you also mentioned regarding tidal volume to be maintained optimal and not too low. Yeah, so and also keeping the hemodynamics in mind, not going too high. So is there any practical tip that you would like to share that you use on a daily basis to make sure that you have set the right tidal volume for the patient, and especially in the setting of severe traumatic brain injury, for instance?
So to me, the perfect tidal volume is a tidal volume which allows me to have a protective driving pressure, a protective plateau pressure, allowing me to maintain a normal CO2 without increasing too much the respiratory rate. I don't know if I have explained. So I set it according to my plateau pressure. Then I do an ABG, and if I have, for instance, already a 20 of respiratory rate, I prefer to go a bit higher with tidal volume, as far as the plateau pressure remains constant. Because as you've seen, tidal volume is importantly associated also with respiratory rate is associated with mortality, and respiratory rate is part of the mechanical power, is a work that the lung does at the end.
Right. Okay. So there is a question from Dr. Manjunath. What is the best ventilatory strategy in traumatic brain injured patients who have associated either obstructive lung disease or restrictive lung diseases? How do we individualize lung protection in these patients without compromising on the neurological outcome?
This is a $1 million question because there is no evidence on this specific population. And in the Ventibrain study, the number of respiratory pre-comorbidities was low because they are young. Basically, the population is a young population. What you have to keep in mind in this group of patients, to me, is that they have a different reactivity to CO2 in terms of the brain and different targets of CO2. So especially in these patients, I will be very careful with reducing the CO2 because their brain is used to higher values. Their autoregulation is used to have higher values of CO2. So you might really cause secondary brain damage in this. So these are the populations where for sure I would use other strategies more than CO2 to control ICP.
Okay, okay, got that. And so we also have Dr. Srilata, who's asked, what would be your go-to strategy for severe traumatic brain injury for ventilating them?
Uh,
If
Everything
you could
I've
just
said.
reiterate.
No, I
Yeah,
mean, yeah, because if you see the mm, the GCS of the patients in Ventibrain, the median was 7, so they were all severe
severe.
traumatic injury. So in reality, everything that was said so far was especially for this population.
Right. And so, in the same vein, um, how do flow volume loops help us along with CPP targets? Is there a combination that we can use?
To be honest, so volume loops, you flow volume loops, you mean the curves and
Yeah,
ah,
the the
okay.
beaking in ARDS that we see. Yeah.
Yes, they can help you, but these are not different from non-brain injured patients. So
Right.
you apply the same criteria, but at the same time you have to maintain a very high CPP. These are patients where you probably will need higher values of CPP, even if they are not hemodynamically unstable or etc. But the other thing about the lung protective strategies is that also allows you to have a sort of more stable hemodynamics.
Okay. And is there any consensus for prone ventilation in traumatic brain injury?
In the guidelines from the European Society of Intensive Care Medicine, it was one of the most discussed point, and we gave a recommendation in favor of prone position in TBI. This is related to a huge number, well, some observational studies which demonstrated no changes in the ICP in prone position as long as the arterial blood pressure doesn't drop, and an improvement of the oxygenation of the systemic and cerebral oxygenation. There are some specific attention that you have to pay in this population because you have to be even more careful about the positioning. So the patient has to stay anyway at 30 degrees, okay? And you have to be very, very careful about the abdominal pressure. So don't, when you keep the patients prone, try to make sure that there is enough space, enough liberty regarding the abdominal part. For the neuromonitoring in prone patients, neuromonitoring was considered one of the traditional complications of prone position, no? So because there was a risk of misplacement, there is a risk of misplacement, so you have to be extremely careful. If the question is if I would add a neuromonitoring in a patient which I put in prone position, I will say that I will probably consider it because it is anyway a risky condition. So if I have a patient who has, borderline indication for ICP, if for respiratory reasons I have to put in prone, I will discuss with my neurosurgeons to put an ICP monitoring.
Okay. And there is one more question about in the acute phase, what is the best intraoperative strategy for ventilation in traumatic brain injury patients? I think they're trying to ask us when the patient comes in for an emergency, say, decompression. what sort of should we go for proper lung protective strategies for ventilation at that time, intraoperatively as well?
Um, so I think there is not a huge difference. If this is the question, I think you mean if a patient has very high ICP, and so there is a risk of herniation, so he has to go for a decompressive craniectomy. This is the only situations where I will go for a profound hyperventilation, especially
Hyperventilation.
if a patient has signs of brainstem compression or similar. I never go below 32 except in the emergency situation where you have a risk of brain herniation.
Okay. That's true.
So two similar questions next coming up.
Yeah.
CO2 targets for OSA and chronic hypercapnia, and the same for obstructive lung disease or restrictive lung disease.
Yeah, this is what I have said
Probably,
before.
yes.
Yes, there is, I think, a different target because the brain and the autoregulation status and the vascular reactivity of this patient is set to a higher level. So what I do is, in these cases, to monitor the CO2 targets also mainly according to the transcranial Doppler values, because with a transcranial Doppler you are absolutely able to assess the cerebrovascular resistance. So you see if you are doing bad to your patient.
Okay.
One probably we can take, and one is from Nitin himself. So we can take the last question from Nitin, and this one is, can you read out, Kanchan?
Yes, ma'am. In a diffuse axonal injury patient who is tracheostomized on spontaneous mode and is tachypnic, what should be the strategy if CO2 is decreasing below 30 millimeters of mercury spontaneously?
Mm. So
Okay.
this is a
Yeah,
very
It's
good
quite a
question.
practical thing, yeah.
actually, yes.
Sorry?
What to do with a hyperventilating patient?
You have to work on that and understand whether this is just Saltarius or if it can lead you to secondary brain injury. So, of course, what I do as in first instance is to see whether maybe the patient is not enough. Maybe he's in pressure support, but the supports are not enough. And otherwise, if he is in total spontaneous ventilation, I start a bit of drugs which can help him to be more calm and relaxed. We use as first drug the dexmetomidine. And generally, the patients have a very good response.
Right.
This is the last question.
Dr. Nitin, would you like to ask the question yourself?
Yeah, so I just want to know, Dr. Chiara, what other neuromonitors other than ICP monitoring would you use when you're generally doing lung protective strategy ventilation in suppose a TBI patient? So what other monitors would you routinely use in your ICU practice?
So we are super fan of non-invasive methods in my ICU. So we do transcranial Doppler to everybody. This is for sure. We have NIRS, but if we are in a patient with severe TBI with also respiratory complication, PbTO2 I think is probably the best.
Jugular? Do you use jugular oximetry in your practice?
Sometimes when we don't have PbTO2 available, but the problem with jugular is that to detect a cerebral ischemia, a cerebral desaturation, it means that you have already a huge part of the brain which is suffering, and it only looks one part of the brain. We generally tend to use the PbTO2, which is put in the penumbra area, which likely is the first part of the brain that starts to suffer if you are not good at managing them. But to be honest, I really like jugular venous oxygenation because it helps you a lot in understanding, for instance, the pathophysiological mechanism of oxygen extraction. And there were cases where we used it and we target the CO2 also according to that. Because of course, if you have a vasodilation, there is also an improvement on the oxygenation and the other way around. So sometimes we use also that
Do you use optic nerve sheath diameter also, like to
all the time.
non-invasive, very.
Yeah, we use it. We use it a lot.
Yeah. Also, so now, just to summarize all of this, I would just like to ask you, what ideal changes would you like to see after seeing all the ventilatory trends and practices? Is there something that you did not like that you would want to see changed, probably all over the world, or if there are some strategies that should not have been there, and then you notice those, what would you like to see change?
What I didn't like, this means that with the guidelines I didn't do a good work, is the variability across centers. Because I think now we have enough evidence to
Mm.
have some general and universal concept. So I would like that all clinicians, could stick together and work in the same way. Then what I didn't like, of course, I have my view. Uh, I was a bit surprised, and I think it's something that we need to work on, is that many centers didn't calculate the driving pressure. Then it was calculated by us afterwards, but this means that it's not a parameter that clinicians use at bedside, and I feel it's very important. So we need to increase awareness of the importance of more sophisticated parameters like driving pressure, mechanical power, etc., because it can help.
Okay,
Okay.
excellent.
Thank you
Yeah.
so much, Kansan. I think you don't have any more questions.
Yeah, we learned a
Very much.
lot. We did pick up a lot of practical points as well. Because, like I said, it's like, we have to look ourselves in the mirror, and this one study showed us that. And we can only work towards improving our
Good
ventilative
point was
strategies.
like many people are not using very high tidal volumes. I think most of
That
the
was
centers
great.
are already using low tidal volume,
Yeah.
so we
Yeah.
are well aware. Yeah,
Yeah.
but that's a take that what is ideal and what is lung protective is remains a question. So
Yes.
thank you very much, and
Thank you.
we enjoyed listening to you and hope to see you sometime soon and also collaborate sometime. Yes,
With pleasure.
thank you. Yes, thank you
And
so much.
thanks to
Nitin,
all the
any words of wisdom from you? We have not listened to you at all. Nitin?
No, so I think there is a lot of room for collaboration here. So complex questions like these and complex areas like these, where there get a lot of gray areas, need a lot of collaboration. So hats off to Dr.
Yeah.
Chiara and her team to get all parts of the world well represented. It is very difficult to do such studies, to get people from all across the world, to have them motivated to do to give data. So in our country also, we offered this to many centers like. My chief Massimo, he tried to get in many centers, but we still have to get there where we want to find answers to these questions. So collaboration is the key, and I think India has a lot of data. Quality work is going on. India has to contribute more. So I think Dr. Kiara, next time I think you'll have a lot of collaborators from India as well who will be
Yeah,
wanting to be part of your studies. So a lot of
Yes.
room for involvement and collaboration here.
with pleasure.
Sure.
I-
Really.
If I may, there's just one point that if we could also include a lot of non-invasive ICP monitoring,
So
I
she
Yes.
has
think,
recommended that. She has recommended
yeah,
non.
because
She is a strong supporter of use of ultrasound in brain.
absolutely. Then we can also have more and more centers that can participate because a lot of us don't have invasive ICP monitoring on a routine basis.
I
So
know.
Yeah.
ICP monitoring concern was not actually, Dr. Kiara, I think it was not a mandatory thing. So in our center also, we do not do too much of invasive ICP monitoring. So but still, we recruited patients. So that's what the variability, what I think she was looking at.
Yes.
Thank
Thank
you.
you
Okay.
very much.
Thank you very much.
Ventibrain.
See you.
Thanks.
Thank you, Dr. Chiara.
As
Thank
the
you for your
second
time.
team,
Thank
we
you
can
all.
remain in the room for a minute and then we can leave. Just a minute.
Yeah, thank you to the audience.